Hi there. Today we're going to talk about Chapter 31, Allergies and Anaphylaxis, and so we should be making a determination between the two. We'll talk a little bit about the patho, some of the assessment findings in anaphylaxis, management of anaphylaxis, which is a true emergency, assessment findings in an allergic reaction, management of allergic reactions, and patient education, how to keep the public aware. So an allergic reaction is a response from the body to any kind of a foreign substance that initiates things. So you can have an allergic reaction to, we'll say, hay fever or dust or pet dander, and that can cause sneezing, runny nose, watery eyes, and that's generally what we term allergies. Whereas anaphylaxis is a true emergency. This is an unusual or exaggerated allergic reaction, and it's much more severe and can be life-threatening. So make sure that you discern between the two of those. Oftentimes when you ask patients at the onset of your assessment, do they have any allergies? Make sure that you ask whether they have an allergic reaction to something. If they say they have allergies, well, I'm allergic to dogs, or I'm allergic to cats or grass or whatever, make sure you discern between that and a medication that you're about to give them, whether they've had a severe reaction to it before. Most people, if they've had a severe reaction to a medication of any kind or type of medication, they will tell you up front as quick as they can. So what is the problem here? We've got an immune system that's on high alert. You have pathogens. My simple term for that is cooties, but the pathogens get into the body either by breathing them in, by touching on the skin, injection, like toxins, for instance, that can get into the body, a wasp or a bee sting, and those types of things get into the body, and the body reacts to it. So we've got antibodies that are in the body that are kind of like, this is the way I think of it, is like a library. If you have certain pathogens that enter into the body throughout our lifetime, as from birth to death, we have exposures to various things. So as we have those exposures to those particular cooties, if you will, then our body learns what antibodies to send out. It builds up antibodies. It learns how to attack and defend itself, attack the invader and defend itself. So it puts that in a catalog, in a library in your body. And once you've had that exposure, the next time you have an exposure to the same cootie again, the body will send out whatever it needs to do as far as those antibodies. So that's kind of the best way I can think of that. So our immune response, any kind of exposure to that antigen or that pathogen produces a primary response with general antibodies. So that's just a kind of a typical response to anything that enters into the system. We develop that antigen-specific antibody and memory. So again, we catalog it, we put it in the back archives, and if we have another exposure to XYZ cootie, then the body will go ahead and say, all right, what antibodies do we need to send, how much, what do we do? And the body's prepared for it. Future exposures generate a faster secondary response. So that's good for us if we want to attack something that we've had a reaction to and we want to suppress it quickly. But it can be bad in the sense that we have anaphylaxis, and that's why we're so concerned with anaphylaxis. It's that first exposure that's bad, but the second one is the one that typically will kill you. So that first time we have a bee sting for a small child and they swell up and they have a really bad reaction, the second time that reaction is going to be quicker. So remember the difference between natural and acquired immunity. That natural immunity we get from just being in, I think of the kids going to daycare and getting runny noses and colds. They're all running around each other. They're acquiring, or they're getting that natural immunity, and acquired immunities in that area. The natural from the mother, from breastfeeding, for instance, or in the womb, and then acquiring it from being around other children, exposures to other things. So that's why daycare years for your kiddos are difficult, because they're sick a lot. That they're building that immunity up. We've got induced active immunity. Remember, we have shots We have injections, vaccinations that we want to give the body a little bit of an exposure to a specific pathogen, build up the antibodies so that if we do have another exposure, we try to ward that off with that particular pathogen. So we do that on purpose. Active and passive, so think about the different parts of your body that react. So acute immune response on this diagram here, you have any kind of cellular injury to that mast cell, and it's going to have a massive release of histamine, and you've got that chemical release that's into the bloodstream rapidly. So that's why we think about Benadryl, Benadryl being a antihistamine, also known as diphenhydramine. So we've got vasodilation, so you've got massive vasodilation, so that drops the blood pressure. You're going to feel warmness or heat and redness, I'm sorry, at the site. Vascular permeability, so we've got a lot of leaking vessels that are leaking into the other spaces around the vessels. The interstitial spaces swell. So you have, we'll say a bee sting, then you've got swelling, edema, redness, pain at the site. May have the pus there. Thrombosis could be a possibility. You could have some clots, and then stimulation of that nerve ending. So a lot of things happen pretty rapidly with an exposure to a pathogen like that. So allergies, that's a sensitization. My wife, for instance, if she drinks a glass of wine, she gets splotchy. She turns red on her neck, cheeks, and that's kind of a sensitization. She doesn't swell up. She doesn't have problems breathing, but it's something that she's sensitive to there. You can have a hypersensitivity, which is delayed, results from cellular immunity and does not involve the antibodies. So you've got that skin rash. Think about any kind of chemicals. Both of my kids have really fair skin, so it's very easy for them to get a skin rash or just even brush up against grass and then their skin turns red. You can also have results from exposure to certain drugs or chemicals, so think about that. Any kind of exposure there could result in a delayed hypersensitivity. An immediate exposure provides quick results, and then you've got a secondary response, so it's more severe than a delayed hypersensitivity, and you just have that automatic reaction. So think about somebody being exposed to cats or cat dander and then starting to sneeze, their eyes water, their face swelling, having that allergic type issue. An allergen is something that we have that exposure, and it has that secondary response. So we've got large quantities of that IgE antibody that's released into the system. There's a huge chemical release, and then we have an allergic reaction. That includes histamines. So in other words, we've got that release of histamines, heparin, other substances or chemicals within the mast cells designed to minimize the body's exposure to an antigen. So it's just kind of like it's a natural response, but it's more than we expect. That histamines cause bronchoconstriction, so we want to reverse that. Vasodilation, we want to reverse that. Increased gastric motility, increased vascular permeability. So multiple areas are being affected at one time. So think about the different agents that may cause anaphylaxis itself. Foreign proteins, foods are becoming more and more popular. Nuts, eggs, and shrimp are very common. So things that were manufactured, I noticed labels that say manufactured in a plant where peanuts are produced, even though that particular item has nothing to do with peanuts. They're placing that on packaging now. So we've got to ask the patients what they were exposed to if they have a reaction. Shots, think about your extracts that are made there. Bees, wasps, insulin, any kind of blood products we could have a reaction to. So there's a lot of things out there. I've even had a patient in the past that was allergic to Benadryl, and that got interesting. So believe it or not, people can be allergic to anything. So anaphylaxis, think about your severe cause, an injection. Most of anaphylactic reactions are from an injected allergen. So Think of your wasp and bee sting is up there as being the highest thing. And of course, the main time that we see those types of things is in the spring and in the summer when people are outside, they're more active, and those types of insects are more active during the warmer months. That's when you've got more of those instances occurring. The allergen rapidly distributes throughout the body, so with that injection, it's in the bloodstream immediately, and it's being sent around throughout the body through the circulatory system, and then you've got that massive histamine release. So you can also think about penicillin. People have reactions to antibiotics still to this day. It's not something that's gone away, so you've got to watch those folks. It affects the cardiovascular, respiratory, and GI system, the skin. You get the hives or urticaria, significant plasma loss. So you've got a lot of vascular permeability, a lot of swelling, and we've got slow reacting substance in the body that's causing those reactions at times as well. So maybe delayed. So history and physical exam, your sample and OPQRST history, rapid onset, usually 30 to 60 seconds. So folks that do have a true anaphylactic reaction will have it rapidly. I've had people call me and say, "Oh, I got a spider that bit me yesterday, and I'm having an allergic reaction to it." Well, that's a long period of time. We're talking about true anaphylaxis. Speed of reaction is indicative of severity, so in other words, they'll just swell up very quickly. Any kind of previous allergies and reactions, again, we need to be really on top of the game. If we know that this is the second exposure for somebody, chances are this reaction is going to be much swifter and more severe. Do a good physical exam. Presence of severe respiratory difficulty is key to determining the difference between anaphylaxis and an allergic reaction. So you've got to be on top of that airway. That's our number one thing we're going to be worried about is airway. So physical findings, we can certainly think about facial, look at their presentation, see if they've got facial or laryngeal edema, if they've got any stridor or pursing of the lips, abnormal breath sounds, hives or urticaria, hyperactive bowel sounds, vital sign deterioration as a reaction progresses. So you're going to have a rapid heart rate, low blood pressure, swelling, redness, itching. The biggest thing to watch out for, again, you may have wheezing again. So respiratory system is probably going to be our number one thing that we're going to focus on. Again, going back to our ABCs always. So just some of the symptoms there, just kind of broken down as to what's affected by the mast cell, that rapid heart rate and decreased cardiac output. If you've got that vasodilation systemically, then the blood pressure is going to drop. You've got all those fluids in the vascular system moving into the interstitial spaces, so you've got edema that can be centralized or it can be everywhere, but generally we see it a lot more like in the face or hands or feet. Itching, hives or urticaria, wheezing in the lungs or shortness of breath. All of those things are going to be, it's just a massive systemic attack. So our management, of course, scene safety, just make sure that if there are any kind of, if there's a huge wasp nest or chemical exposure, we want to make sure that we stay away from that and not injure ourselves. So make sure that you're safe first. Protect the patient's airway. If we're going to do an airway adjunct, make sure that we're very careful with that. If they've got edema or laryngeal edema, be careful about how we think about managing that airway and whether or not we want to put something in there that could cause laryngeal spasm. Intubate early if you've got a severe case. So this may be an issue where we want to go ahead and paralyze the patient and place the breathing tube before we get behind the 8-ball. And that's one of those things. If there's a lot of stridor, patient has low O2 sats, they're gasping or coughing, they can't breathe well, this is the kind of patient you want to get an IV in quickly, secure the airway, and then continue on with the administration of your Benadryl and your epinephrine. And don't be afraid, or be prepared anyway, to be placing a surgical airway if you can't get that tube in place in time. Support that breathing, high flow O2, high con O2. You may have to bag them or assist them with ventilation if they get unconscious. The Establish your IV axis. Again, I want to get that quickly, but it can be difficult sometimes if they're volume depleted, if they've got a lot of vascular leaking or edema. It may be a little difficult to get that IV started, so you need to be confident with your skills and get that IV in quickly. There's a lot that has to be done in a hurry, obviously. Your crystalloid solution, again, we may want to go ahead and ramp that up, and then consider a second IV line if they're having a lot of third spacing there with fluids. Get your meds on board. You definitely want to have your high flow O2, your epinephrine, either IM or sub-Q. It just depends on where you go to work, where your protocols advise you. Don't forget the EpiPen that you learned about in the basic portion of your training. Antihistamines, typically we're going to use our Benadryl or diphenhydramine. Corticosteroids, so you may have a corticosteroid that you're administering that's going to reduce the inflammation. We may want to consider vasopressors, beta agonists, just like your vasopressors, thinking again your epinephrine, your beta agonist. I'm sorry, vasopressors. Think about dopamine. Dopamine, and then beta agonist is going to be your albuterol, opening up those bronchial constrictions, and then anything else that may be within your protocol area. Then again, reassure the patient. I think there's a lot of fear that goes with one of these reactions, so it's important to talk to the patient, look at them, let them know what you're doing for them, talk them through it as you're providing that care. So just kind of a quick look. You can see this in your book, but the difference between an allergic reaction and a true anaphylaxis. And sometimes it's hard to tell. It may start to look like a regular allergic reaction and move into anaphylaxis. I tend to jump on these patients pretty quickly. If I see enough that they've got urticaria or I start to hear wheezing, then I treat them like a true anaphylactic case, and I go ahead and hit them with everything I have. So our general management, again, determine scene safety, protect the airway, support breathing, IV access, and give your meds. Most importantly out of everything is your oxygen, your Benadryl, and your Epi. And notice this picture. I think this is a really good photograph. This kid looks like he's having a real reaction. I don't think this is faked. But notice his eyes, kind of glassy there. Face looks a little puffy. Notice his legs. Looks like he's got some urticaria down on both legs. But he's starting to get a little, out there. You can tell that he's just starting to lose his. He's just not concerned with the fact that he's even getting a shot. So that picture's pretty telling there. The kid's starting to wear down, and that's why he's getting that epinephrine injection in the shoulder there. So any kind of patient education we can provide as part of our job is to go out there and talk about how to prevent reactions, any kind of staying away from bees, keeping an EpiPen close if you have severe allergies or allergic reaction, ways to prevent that, and then how to recognize signs and symptoms. So make sure that they understand to keep those auto-injectors in date. I've had several people that have used them in the past, but it's been 2 or 3 years since they had an attack or a bee sting, and they don't go get the epinephrine pen renewed, so it just doesn't work. And then think about desensitization. So you can get to a point where you're just not thinking that much about it anymore, as well as the patient's physical or physiological changes for desensitization. So think about the patho. We talked about the difference between allergies and anaphylaxis, how to properly manage it and do it rapidly. Findings in the allergic reaction with your respiratory, skin, and other areas that are affected, management, and patient education.